Hi, very good morning, everyone. We are on 18th of October 2025, and in India it is a Dhanteras. Uh, it is it is a very important festival season over here. Today we are covering a very important topic. I was saying very close to my heart. It's on migraine. So, strategies, new drug, new hope, what are the advances, how to manage the migraine is what we are discussing. Often people get confused between a normal headache, migraine, or a radiating pain from some other body. So, all these problems which we are facing would be resolved today. We have Dr. Lieutenant General C.S. Narayanan. He's joining in as a chairman for Manipal Institute of Neurosciences. We are blessed to have him. He's also the president of All India Institute of Medical Sciences, Jammu. He has served 39 years in armed forces. So, sir, we respect you for that and thank you for uh, helping not only the country in terms of armed forces, but also now the general people who are suffering from this medicines of neuro, the problems of neuro. He's a HOD of Neuro in Arm Hospital, R&R. He was a dean and deputy commandant in Army Hospital, R&R. He has various awards under his name and President Honorary Surgeon. President Honorary Surgeon. Sir, over to you.
Thank you so much. A very good morning to you who are joining from all over the world. The topic given to me was therapeutic strategies in migraine, new drugs and new hope. The heading says it all. There are a slew of newer medications which make the life of patients with migraine so much better. We'll run through that, beginning with some aspects of the pathophysiology, what is migraine and what causes it, and what are the molecules involved in the pathogenesis of migraine. And then we will talk about the drugs which are specifically targeted at these molecules so that to make the patient's life better. As we all know, migraine is a major global health problem that affects almost 10% of the population. That means around 1 billion people are affected globally. It is the second leading cause of years lived with disability. The prevalence is around 12% on an average, but it can go up higher in certain age groups and populations, like women in a certain age group have even a higher prevalence. It peaks in middle life. It is the highest in the 30 to 49-year age group. 1/3 of these patients experience headache, which is more than 4 days per month. And that is quite a bit. And 50% of patients report severe impairment or the need for bed rest. These patients may experience functional impairment that disrupt everyday activities. They may have to take leave from office. This is not uncommon. And more importantly, it also disrupts family activities and relationships. So it has got an overall huge impact on the quality of life of these patients. Although not all phases experienced by every patient and with every attack, the symptoms associated with migraine can impact several aspects of a patient's life. And it is divided artificially into several phases. Actually, each has got an overlap with the other. There could be a prodromal phase in which the patient could have fatigue, food cravings, nausea, cognitive symptoms, neck discomfort, which actually the panelist before me was talking about. There could be photophobia and phonophobia, that means sensitivity to light and sound. In some patients, there could be an aura. The aura is predominantly visual in most patients. We'll talk about how it looks like in a couple of slides down the line. And this lasts from 5 to 60 minutes. On an average, it did not exceed 60 minutes. Then you have the headache period. By definition, it lasts from 4 to 72 hours. There is moderate to severe head pain. And during this phase as well, there is severe sensitivity to light and sound. There could be nausea and vomiting. There could be sensitivity to touch. This manifests usually as scalp tenderness. There could be neck discomfort, which is very common. In some patients, there could be watering of the eyes, redness of the eyes, and there are a lot of mood changes and cognitive symptoms as well. The prodrome is very similar to the prodrome, the postdrome, and in the interictal phase, that is in between the attacks of migraine, also the patient could have some symptoms which could be bothersome. This is the slide that I was referring to. It's a very alarming thing. This is a visual aura of migraine, where there is a huge blind spot which gradually expands. It starts in the middle of the field, visual field, and gradually expands and disappears into the periphery, and in a form of a zigzag, and that is usually termed as a fortification spectrum. The clinical findings suggest that migraine can progress over time. About 3% of migraine patients transition from episodic to chronic migraine every year. That's also an alarming figure. And chronic migraine is defined as 15 headaches per month for over 3 months, with features of typical migraine in 8 days, 8 of these attacks. Several factors have been associated with this progression, including the presence of skin sensitivity, nausea, and unresponsiveness to acute medications. Migraine is generally thought about as a predominantly functional problem, which has been studied in the fMRI. But these days, with the sensitive MRIs which are available, 7 Tesla MRIs for research purposes, several structural changes have also been seen in the brains of migraineurs. It has a very complex pathophysiology, and it was not very well understood over the years, but now we know much more about this molecular pathways that underlie the multifaceted symptoms across all the phases of migraine. We have talked about all these phases: the prodrome, the aura, the headache phase, the postdrome, and the interictal phase. And specific parts of the brain are activated during each of these phases. In the prodrome, there is activation of the hypothalamus. In the aura phase, there is what we call cortical spreading depression. The most important part, that is the ictal phase of the actual headache phase, is subserved by several neuropeptides with sensitization of the central and peripheral trigeminal system. We'll talk about this because almost all the headache medicines target the molecules which subserve this part of the headache phase. Activation of the hypothalamus will contribute to the prodrome symptoms, and the hypothalamus is involved, as we all know, in a number of physiological processes, which includes processing of pain. It controls the sleep-wake cycle. It is involved in feeding, thirst, arousal, and also in the regulation of autonomic and endocrine functions. So studies have shown very clearly that there is activation of the hypothalamus before the onset of migraine pain, and this contributes to the nausea, vomiting, changes of appetite, and fatigue, which are very common in patients before the migraine headache starts. Several neuropeptides like leptin, neuropeptide Y, and orexin A and B have also been involved, and there are molecules now, drug molecules, which target these as well to relieve the patient of their symptoms. This is a very interesting phenomena. This happens during the aura phase, and the main pathophysiological mechanism is what we call cortical spreading depression. And this is the primary pathophysiology behind the aura phase. This is spreading depression which propagates very slowly from the back to the front at a rate of 2 to 6 millimeters per minute. There is a lack of blood flow to certain parts of the brain during this period, and this lack of blood flow may actually cause the visual symptoms. Now we come to the main mechanism of that is the headache or the ictal phase. Here there is both peripheral mechanisms and central mechanism involved. In the peripheral mechanism, it is subserved by meningeal nerves and blood vessels, and they propagate their impulses to the trigeminal ganglion to the central pathways. In the central mechanism, there is a trigeminocervical complex which relays its impulses through the thalamus and further to the higher centers of the brain. There are two neuropeptides which may contribute to the pain and sensitization of pathways in the headache phase. And the most important, as we know, is what is called the calcitonin gene-related peptide, or the CGRP. We'll be, of course, talking much more at length about this molecule because most of the drug therapies which are available now target this molecule. There is also another molecule called PACAP. We'll talk a little less about it because there are no specific drug targets for this. Prodrome and postprodrome symptoms are very similar, and they can actually continue throughout the headache phase as well. Now we come to the meat of the presentation, which is the CGRP molecule and how it plays a very important role in migraine, and how several new drugs have been developed to target this molecule and relieve the patient of the headache. The calcitonin gene-related peptide is a 37 amino acid neuropeptide. It is a member of the calcitonin family that includes amylin, adenomalin, and calcitonin. Calcitonin gene-related peptide receptors are found in multiple areas involved in migraine pathophysiology, which include the cerebral and meningeal vasculature, the trigeminal ganglion, the trigeminal nucleus, and the thalamus. They're also expressed on numerous other cell types such as vascular smooth muscles, neurons, glial cells, and mast cells. The role of other receptors in migraine pathophysiology is currently unknown, but the CGRP receptor signaling regulates key events that underlie migraine pathophysiology, including trigeminal-vascular neuron sensitization and neuropeptide release. So this is part of a family of receptors called the calcitonin family. I will not dwell into the details of the receptor constitution, but it is important because these are the targets for the drugs which have been developed recently. I'll summarize it quickly in a graphic form. So this calcitonin gene-related peptide is released from the terminal neurons, and the anti-CGRP monoclonal antibodies target the CGRP. And some of the drugs also target the CGRP receptor complex. So some of the molecules directly target the CGRP, some of the molecules target the receptor complex. This mechanism of CGRP and CGRP receptor signaling is involved in several steps of migraine pathophysiology like vasodilatation, nociceptor activation, neurogenic inflammation, central sensitization, cortical spreading depression, central trigeminal sensory activation, hypothalamic dysfunction, and descending control of brainstem. As you see, it targets almost all the parts of the pathophysiological mechanisms responsible for all the phases of migraine. It has been seen that CGRP levels are increased in migraine sufferers in research work. Triptans, which have been traditional medications which are used in the acute phase of migraine, have also been shown to suppress CGRP release from trigeminal nerves. Sumatriptan acts by the presynaptic 5-HT1BD receptor to suppress the CGRP release from trigeminal nerves. As you see, they act on the presynaptic pathways to decrease the release of the CGRP from the nerve endings. Now we talk about the treatment. We all know that there are two types of treatment for migraine. One is when the patient actually has the attack, and secondly, in those patients who got very frequent, severe and disabling attacks which impact the quality of life, we do give preventive treatment. So acute treatment is used to abort the migraine attack. The potential benefits are it provides immediate symptom relief. However, Adverse effects can be there, which result in tolerability issues. And also, when the patient pops in too many of these pills over a period of time, there is what we call medication overuse headache. And this causes a vicious cycle where the patient has headache, the patient pops in a pill, the patient has more headache. So it's a very vicious cycle and difficult to treat. So that is why in patients who got frequent headaches, we must resort to preventive treatment as well. This is used to reduce the frequency, duration, and severity of the attacks. We must very clearly tell them that there is no cure for migraine. The expectation should be tempered by telling them that the aim is to make their life better, not to provide a cure such that they will never have a headache in their life ever again. The potential benefits are they may avoid escalation in the use of acute medication. Like I said, it can cause medication overuse headache, and it reduce the overall cost associated with migraine treatment. However, they also have several limitations, particularly the current crop of medications which we commonly use. They're associated with patient adherence issues because there are a lot of side effects. The side effects are very common, which include depression, cognitive dysfunction, sleepiness, constipation, and weight gain. So this is another important slide. The commonly used preventive medications are actually not specific to migraine, but they are drugs we use for several other conditions, and this kind of sometimes baffles the patients. So we use beta blockers, which are also very commonly used for blood pressure. We use anticonvulsant drugs. We use antidepressants. So all kinds of drugs are used for prevention. And so the patient says, I don't have a seizure, why are you giving me anticonvulsant medication? Or they say, I don't have depression, why are you treating my migraine with depression, antidepressants? So this needs to be carefully explained to the patient that these are all drugs with dual effects, and they do work very well in migraine as well. So now we move on to the newer advances. The first drug which was developed, which is approved by the FDA in December 2019, was a 5-HT1F receptor agonist administered daily in a dose of 50 to 200 milligrams called lasmiditan. But however, it is being introduced in India as well. But most of us are a little uncomfortable with its use because there is a high amount of sedation and they're not allowed to drive for several hours after taking this medication, which may impact the quality of their life. GPANs are very important. I'll talk to you more about the GPANs and the other available monoclonal antibodies shortly. So the other monoclonal antibodies are the specific CGRP receptor monoclonal antibodies, which are given parenterally. Parenterally means either subcutaneously or intravenously. The first drug to be introduced in India was this medication adalimumab. This is given subcutaneously in a dose of either 70 milligrams or 140 milligrams. It is given once in 4 weeks. The other 3 drugs are not available so far in India. They're eptinezumab, fremanezumab, and galcanezumab. These are given intravenously or subcutaneously in an interval ranging from 4 to 12 weeks. So they're given very infrequently. They're not given every day. They're given either monthly or 3 monthly. History in migraine therapy, which dates back almost till 1982, but it's only in the recent years, maybe in the last 5 to 6 years, that several of these molecules have been tested clinically and approved for therapy. So this is something that I had alluded to earlier. The anti-CGRP antibodies are eptinezumab, fremanezumab, and galcanezumab, which act directly on the CGRP molecule. Whereas the anti-CGRP antibody erinumab, which is the one which is available in India, acts against the CGRP receptor directly. All the newer available molecules, which are called CGRP receptor antagonists, are the GPANs, also act against the CGRP receptor. So the aranumab and the newer GPANs all act against the receptor. The other intravenously given CGRP antibodies act against the molecule itself. So what are the primary differences between the monoclonal antibodies and the traditional preventive anti-migraine medication? Firstly, the traditional migraine medications, like I told you, they are usually anticonvulsants, beta blockers, and antidepressants. So they are not specific to migraine treatment. They're used for several other conditions as well. Whereas the MABs, the monoclonal antibodies, which are used for episodic and chronic migraine, are very specific for migraine treatment. The earlier formulations were also always given as tablets. The newer formulations are given the monoclonal antibodies either subcutaneous or intravenous. The traditional prophylactic treatment had to be given very slowly. They had to be started in small doses and escalated. Start slow and go slow. Whereas the monoclonal antibodies can be given in the optimum doses right from the word go. The traditional agents, the beta blockers, the anticonvulsants, antidepressants are to be given daily. Whereas the monoclonal antibodies are given either monthly or every third month. This does not include the GPANs. We are talking about the monoclonal antibodies. The onset of action of the traditional prophylactics is very slow. So you have to tell the patient that you start the medicine now, but you expect the treatment to take effect in a few weeks down the line. Whereas when you give the monoclonal antibodies which are available to us now, the response is very quick, within 1 week or so. Most importantly, the traditional anti-migraine medications which are given for prevention had weight. The patient used to become a little overweight. When they use, their mood used to change. They used to become drowsy. They used to complain of fatigue. Their sexual dysfunction were very common. Dizziness. So there's a slew of side effects associated with the traditional prophylactic medication, and none of these was observed with the newer medications. So this graphic differentiates between the GPANs, which are called the low molecular weight agents, and the high molecular agents are the intravenously, subcutaneously given monoclonal antibodies. I will not dwell too much into this, except to say that the GPANs also given daily or SOS, whereas the intravenously or subcutaneously given agents are given either weekly or 3 months, once in every other week or once in 3 months. So the daily small molecules, here we are talking about the GPANs, so they're given daily, whereas the monoclonal antibodies, which are parenteral, are given very infrequently, but their effect lasts for a long time. Just a very small graphic to tell you about the use of botulinum toxin in chronic migraine. It is pretty effective, but it is uses very limited. It is given in patients only with chronic migraine and not with episodic migraine. It is very expensive, and it has been repeated once in 3 to 4 months for a sustained effect to be seen in patients. So we are not able to exhibit botulinum toxin therapy to a large number of our patients. Now, a little recap on the main thrust of today's presentation, the newer agents. The newer agents are, as I said, the GPANs, the small molecules, and the anti-CGRP MABs, which are given parenterally. The GPANs are given either orally. There are some agents which can be given by a nasal spray. The orally administered agents are ubrogepant, rimegepant, and atogepant. The nasally administered molecule is called zavegepant. The most important advantage over the traditional acute therapy is that these do not cause vasoconstriction, and therefore they avoid triptan related cardiovascular contraindications. This is very important because migraine can affect elderly patients also, and many of them have comorbid cardiovascular conditions, and in those patients, triptans are contraindicated. So we can use our GPANs in these patients. The parentally given anti-CGRP antagonists are erinumab. Like I had told you in the graphic, it acts directly against the receptor. The other agents, galcanezumab, fremanezumab, and eptinezumab, act against the ligand, that is directly against the CGRP molecule, which is released from the terminal nerve endings. They have long half-life, and they can be given either once a month or once in 3 months. Now to zoom in further into the GPANs, Rivaroxaban is the only agent available, and this is also introduced very recently in India as an orally dispersible tablet of 75 milligram strength. It has some drug-to-drug adverse effects. You must be aware of those. I will not go into the detail. So it is used in patients who do not respond or insufficiently to the traditional acute therapy like triptans. It can also be used for prevention, in which case it is given in a dose of 75 milligrams every other day. The most important thing, like I said, it does not cause any vasoconstriction. The other 3 agents are not available in India. They're ubrogepant, which is used only for acute treatment, and atogepant, which is only used for prevention. And zavegepant is the intranasal formulation. All these agents have been shown to have very good effects on the basis of several trials. They have higher 2-hour pain freedom and freedom from the most bothersome symptom, which are the commonly used yardsticks in all these trials. So now you may ask me, how do these GPANs compare the triptans which have been using for several years in the acute treatment of migraine? Direct head-to-head randomized control trials are scarce. However, network meta-analysis consistently show that most triptans produce higher 2-hour pain freedom than GPANs, but with more adverse effects and vasoconstrictive risk. So we may confine GPANs at the present point of time for those who have insufficient response to triptans or those with cardiovascular disease or cardiovascular risk factors. To summarize the acute treatment of migraine, some of these patients may actually respond pretty well to traditional medications like acetaminophen or brufen. And this can be combined with some antiemetic like domperidone. So they may not require any of the migraine-specific medications. So they're quite happy to pop in this, particularly when their headache is very infrequent. Some of these patients may have headache as infrequently as once in a month or once in 2 months, maybe once in 6 months also. So for them, this medication will be perfectly fine. So we may not actually suggest any migraine-specific medication to them. The second is when we use triptans. Triptans are also very effective. They cause a lot of pain relief within 2 hours of administration. They can be repeated if the response is inadequate after about 4 to 6 hours. GPANs are ubrogepant, rivaroxaban, zavegepant are used when triptans are contraindicated. Like I said, atogepant is only for prevention, but all these other agents can be given for acute treatment. Titans, as I said, are also available, but they are less popular because of their side effect, predominantly sedation and the warning against driving for several hours after taking the treatment. So this summarizes the treatment of acute migraine. What about prevention? So as I said, the main GPANT and which is used only for prevention is atogepant, which can be given in a dose of 10 milligram, 30 milligram, 60 milligram, depending on the patient response. Rimegepant, which is commonly used for acute migraine, can also be used for preventive migraine, but it is not been approved for this indication for in India. Anti-CGRP MABs, as I told you, are very effective, and onabotulinum toxin A, that is Botox, is used only for chronic migraine. So, what are the strategies for preventive treatment of migraine? To summarize, the anti-CGRP targeting therapies, the monoclonal antibodies and the GPANs are now the first line options, according to the American Headache Society recommendation of 2024. Previously, there was a need for them to fail the legacy preventive first, but that caveat has been removed now. In EU and UK, atogepant has been approved for adults with greater than 4 migraine days per month, but provided they have failed 3 of the preventive treatments. Having said that they are very effective, we must also be aware of some safety signals. These are the GPANs. We know that the GPANs and MABs do not constrict arteries, and so they are preferred in patients with cardiovascular disease or risk, or those in patients where triptan is contraindicated. But some of these agents had, the earlier agents, not the current ones, had hepatotoxicity and had to be actually withdrawn from the market. And they do also have a lot of drug-to-drug side effects. I will not talk about the drugs which are specifically implicated, but we must know about these interactions before prescribing these agents. Medication overuse headache, which is very common with the commonly used medications like acetaminophen and ibuprofen, does not happen with GPANs. Can we use GPANs in pregnancy and lactation? There is insufficient human data, so we should not use them unless there is compelling need. In pediatrics, there are a lot of trials which are involving children, and hopefully they'll be available widely for pediatric use in times to come. To conclude, over the last 5 to 6 years, migraine care has shifted from non-specific agents toward therapies that precisely target the calcitonin gene-related peptide, the CGRP pathway. And now we have both small molecule GPANs and large molecule monoclonal antibodies, along with onabotulinum toxin A for chronic migraine. And we have also figured out ways to optimize the use of triptans and NSAIDs. In 2024-2025, guidance has sharpened. CGRP preventives are now first line in AHS statements. New formulations have arrived, like the use of intranasal zavegepant, which is very convenient for patients. And in India, we have issued the approval for the first CGRP GPANT, and that is rimegepant ODT for a defined acute indication. Thank you ever so much for the patient hearing. I'm open to take questions. Thank you again.
So, sir, thank you so much for the wonderful, insightful information on a very, very important topic. So we will open the hour for question answers. Anybody has a question, please raise your hand and unmute and ask question. So we can close the screen share so that we can see the audience. Yes, I welcome everyone on board. I think we have about 20 participants. I welcome all the doctors and dignitaries here. Please go ahead and ask questions. So one question we have on the social media is that what specific test or scans are needed to confirm the exact migraine diagnosis? Is there anything like that?
very important question. So the diagnosis of migraine is purely clinical. So I keep telling it is made on the basis of the questions asked by the doctor and the answers given to the patient. No test is required to confirm the diagnosis of migraine. However, in some patients, we do ask for some tests to exclude some other conditions which may mimic migraine. So there is no test which is required to confirm migraine, but we do ask for tests like an EEG or an MRI to exclude other diagnoses when there is an element of uncertainty in our minds.
Thank you. Dr. Angelique, please go ahead with your question.
Thank you so much for a very, very informative session. I, as you correctly said, because that question always comes up, you know, doctor, I need an MRI, well, I need a brain scan, because in a patient's head, a headache means there's something wrong in your brain, and you can actually pick it up on a special investigations. And you are correct, we can't pick it up. It is a clinical diagnosis. And I think what makes the migraine treatment so much more difficult is the wide use or the umbrella use of the term migraines for anything that is a headache. And I think there needs to be a lot of education to the public and the doctors out there regarding what is really a migraine versus all the other different types of headache or headache syndromes that one can get. And maybe if you just briefly can explain to us just the most, you know, differential diagnosis on this, the 5 or 6 most important ones that we need to differentiate from. Thanks.
Yeah, if I understand correct, you were asking about some conditions which can mimic migraine, right?
Yes. Yes.
Yeah, so there are some red flags which we call so we do have to investigate further when the person has got any of these red flags. Firstly, as we said, migraine is a chronic condition. Suppose a person comes to us with a very recent onset of headache, particularly which is severe and there's a crescendo pattern, it is getting worse. So that is one red flag. Elderly patients, we must be a little careful, because migraine usually affects person of the middle ages. We said the patients around the 30s usually, that is the peak incidence. But if a person comes to us at 50 or 60 years, we must not jump to the diagnosis of migraine. We must look for other causes. Those who have systemic features, you know, they have comorbid conditions, other medical conditions, we must definitely investigate further. So like the person could have a brain tumor or a vascular condition, so we must do that. We must also be a little wary in persons who are immunocompromised. So these patients could have very high incidence of other causes. So it is even when we are relatively certain about the diagnosis of migraine, when several of these red flags are there, so we should investigate further.
Thank you.
Sorry, thank you, sir. So what exactly is the tension headache, and how is that different from migraine? That's one question. And also the second question, which was just a follow-up question for what Dr. Angelique, and what was the question was that usually when there is a headache, doctors jump to the conclusion of get an MRI done. How can that be avoided? Like specifically, like how to be sure that I know it's a clinical diagnose, you already mentioned it, and so how to rule out that yes, you don't need a MRI?
So to answer both questions, the first is the differentiation between a tension headache and migraine. Migraine is not a diagnosis of exclusion. There are several criteria which have to be fulfilled before we diagnose migraine, and all these criteria are clinical, to be sure. It is not that there are some specific tests. And some of the most important criteria are the duration of the headache. There is a specific duration of 4 hours to 72 hours. So if the headache is like for a few minutes, it is usually not fit into the pattern of migraine. So the duration is between 4 to 72 hours. It is usually involves one side of the head, though subsequently it can involve the rest of the head as well. There is sensitivity, this is what we call scalp tenderness. So when we touch the scalp, and this is what I refer to as cutaneous allodynia. So there is scalp tenderness. It is throbbing in character. The character of the headache is also important. And there is sensitivity to light and sound. On some persons have got sensitivity to smell as well. This is called osmophobia. They're usually relieved by some regular painkillers as well and by sleeping. There could be a family history. So these are all very specific criteria which have been defined in the International Headache Classification. On the other hand, tension headache is a little more nebulous. These patients have almost a headache which is band-like, which is constricting, and which almost happens every day. It is aggravated by stress, and they do not have these specific criteria which define a migraine episode. So it is important to differentiate between the two because the management is quite different. If you give anti-migraine medication for a patient's tension headache, they may not get better. And on the contrary, if you give tension headache medication or regular painkillers to patients with migraine, they may not get better. Talking about the imaging, it is all about the threshold. Like I said, there are specific red flags, which in which case you must investigate the patient further. And some of them, like I said, are recent onset of headache, elderly patients, those with comorbid conditions, those who've got compromised immunity, or they have abnormal neurological examination. There is no doubt. So they may require imaging like an MRI or CT scan, as also several other tests in addition to these things. On the other hand, some patients are very apprehensive. Even if you are trying to convince patients that, okay, you don't require an MRI, because the headache is so disabling, so frequent, and so bothersome, they're just not convinced if you don't investigate them further. And in some patients, the doctor also may be genuinely worried that they should not be missing out other conditions. So it's a threshold dependent thing. But guidelines do definitely say in typical case of migraine, you do not require an MRI. But in practice, there are a lot of gray areas.
So excellent answer, and I think that answers the person's question on the social media. Do we have any other questions on the floor while I'm looking for more questions? I think we have few of non-doctors as well. If somebody wants to ask questions, please go ahead and ask questions directly from the doctor. So one question is, this is again a very good question. Coffee or caffeine? I think it's a youngsters thing, which is too many of coffees happening. So is coffee, dehydration, and caffeine related to migraine, or can trigger migraine?
I saw also a pop-up about some foods to be avoided. So I'll answer both the questions together. So there are several triggers for migraine. Okay, so the patient, firstly, the brain is normal, but the brain is sensitive to certain triggers. The commonest trigger is, I would say, in India, fasting. And all these vrats and Karwa Chauth and all that is a very potent trigger for migraine. So I know we know how we pass through that phase. We had a sudden spurt of patient with migraine. Second is sunlight. Third one is strong smells like perfumes and all that. Food triggers are very well defined and very well described as well. Some of them are alcohol, certain types of Chinese food, additives like Ajinomoto, some types of cheese, some types of red wine. As far as caffeine goes, some patients actually get better. And in some it triggers migraine, particularly they overuse caffeine, which is present both in coffee and cola beverages. So it depends on whether you improve or you don't improve, but in any case, there is no case for overuse of caffeine. So that is going to do more harm than good. So if you have any of these food triggers, whatever is specific to you, they are not common and they're not like present in everyone. So there's no blanket ban on any type of food. But if the person has noticed a specific food aggravates their migraine, that type of food should be avoided.
Just to add on this, what about the screen time? The screen time is increased for again the people.
So again, screen time, as we all know, is very unhealthy. Generally, as a lifestyle choice, we should avoid too much of screen time, and all of us doom scrolling these days. That is not very good for general health. But it is not a specific trigger for migraine. But having said that, like I said, the triggers for migraine so non-specific. So in an individual patient, if screen time is the trigger, obviously that should be avoided.
So I think in nutshell, what we are trying to say is that there are a lot of triggers, could be sleep time, could be a specific diet, could be fasting, or it could be even the lifestyle disorder, it could be sleeping habits. So you should evaluate yourself clinically before you go to doctor and see what triggers so that even doctors can help and what time the migraine is coming.
Absolutely. And to this end, there is a thing called a migraine diary. So the patient records very specifically in a diary what are the days in a month that the patient had headache, what they did to make it better, what are the triggers, what happened when they removed those triggers. So all these are details are recorded over a period of a month. And when they visit the doctor, they present this diary to the doctor. The doctor evaluates all these and modifies the treatment choices accordingly.
So I just want to personally say something what I used to follow for my mother is that I used to have an AI chart, on the phone itself. It gives you a link. You can create it yourself on Google Forms. And whenever she had a specific problem like migraine or something, I used to monitor her blood pressure also that time because a lot of times blood pressure is also a problem. And I used to write specifically what time she had a migraine, what on that particular day did she fast, did she not fast, and probably a week record data really helps specific what to diagnose and how to diagnose. So, Dr. Ravi, I believe you are there, Dr. Prakash, Dr. Kute, Dr. Pillai.
Yes.
Anybody has? Yeah, please go ahead and ask questions if you have.
No questions from me, Saurabh.
Okay. So I think, sir, I don't think we have any other questions. There are some general questions about smell, about sleep, about drinking habits, about alcohol. I think all those questions have already been answered in your general part of it. What diet can be prevented from migraines, all these things, dairy products, neck visions, eye testing, I think all these things are covered in your presentation. So I'll skip those questions in the interest of time. But this is the last call. If anybody has a specific question, please go ahead and ask. Otherwise, we will probably close the session for today. Okay, sir. So I think there is no questions. I think we've answered most of the questions. With this note, I would like to thank you for the wonderful presentation, wonderful insight. I think this is a topic which we will always have, a lot of problems coming up later. So I thank you for your time, and I think we are dot 10:30, so we have covered a 1 hour session. Thank you for joining us. We will invite you again for a follow-up session. It was a wonderful presentation, wonderful knowledge, and we thank you for so much for serving the nation and now helping us to get off the migraine.
Great pleasure to join all of you and also to all the participants for making it so interactive. And let us all pray that we remain free from migraine ever after.
So you can just give a take-home message if anything for our audience.
Yeah, the take-home message, most important is that not all headaches are, migraine, and we should not ignore migraine as any other headache because the treatment is so totally different. I have several patients who come to my clinic who said that, okay, we've had headaches and we've not kind of taken any specific treatment so far. And they respond dramatically to all the therapeutic options which are available now. But like I said earlier in my presentation as well, despite all the newer advances in the treatment, there is no cure for migraine. We should temper the expectations of the patients. All these medicines are used only for either acute treatment or prevention over a certain period of time. So once we put all these things on the table, the quality of life of these patients improves dramatically, their work life, their personal life, and most importantly, the economic output of the nation. Actually, it has been studied that there's a huge impact on the economic output of the nation if migraine is not tackled as a public health measure.
Also, there's one question which I missed out in the chat from Dr. V.V. Raghunath is how can we rule out the genetic cause? We'll answer that last question, I think.
Yeah, sure. So migraine is, if at all, is a gene kind of a thing. There's no specific gene for the most common varieties of migraine. Okay, so there is a very strong family be some family history, but there is no single migraine. I will not cover all the subsets of migraine. Specifically, there is one condition called familial hemiplegic migraine, where they have episodes of paralysis and also associated with headache, and these are associated with certain gene abnormalities.
Excellent, sir. So I think with this note, we would like to close the session, and we thank you, the speaker, for giving us a good Saturday morning. And I wish everyone a festival season, and see you again next time for the next session and the next topic and the next speaker. Thank you so much, everyone. Thank you for joining.
Okay, happy
Okay,
Diwali.
thank you. Namaskar to everyone.